Hello, my name is Yiming Koo. I'm a GP from Malaysia, and today I'm going to present a case study on adult with seasonal allergic rhinitis. This case study is prepared by myself and Dr. Jaime de Souza from Portugal. And the case study is part of a series of case studies that IPCRG has prepared as part of a rhinitis right care. In April this year, 2025, IPCRG has published a desktop helper number 19 on a practical guide to improve rhinitis diagnosis in primary care. The aim of the desktop helper is to help clinicians to reduce misdiagnosis and increase clinicians' confidence in diagnosing and managing rhinitis. We all know that rhinitis is a highly prevalent condition in all age groups, and underdiagnosis and misdiagnosis are very common. So the learning objectives of this case study are that participants should be able to list some of the challenges in the diagnosis and management of rhinitis, to assess the impact of patients' symptoms, considering the patient's ideas, concerns, and expectations, and to design a personalized management plan, including non-pharmacological and pharmacological approaches. And lastly but not least, to identify red flags and know when to refer. So Hannah is a 26-year-old male carrier. She has runny, itchy, and blocked nose with sneezing and sometimes itchy eyes for the past month. These symptoms has become worse in the last week and are affecting her work. There is no wheezing noted. She has been using oral antihistamines that she purchased over the counter and nasal decongestants, which seems to help for a short period of time. She has noted that she has been having these symptoms intermittently since her childhood, and every year during spring, her symptoms would get worse when she walks near the gardens or the parks. She does not have any other illness, and her father has a history of asthma. She does not smoke and avoids smoky environments. On clinical examination, she is mouth breathing, there are frequent sneezing and throat clearing. There are dark circles under the eyes that are called allergic shyness, and there are presence of infraorbital skin fold and a transverse nasal crease. On nasal examination, there are profuse light-colored aqueous discharge from both her nasal cavities, and both her turbinates were swollen bilaterally. There are no polyps, and her nasal septum is not deviated. There is no sinonasal mass, nor foreign bodies, and her sinuses were not tender. And a diagnosis of allergic rhinitis is made. Now, for the management of allergic rhinitis, one can prescribe non-sedating H1 antihistamine and/or a nasal corticosteroid, or a fixed combination of nasal glucocorticoid and nasal antihistamine. One can also consider serum testing for allergen-specific immunoglobulin E and allergy skin prick testing. In Hannah's case, she was given a non-sedating H1 antihistamine with a nasal glucocorticoid. And she returns after 12 weeks. Although her symptoms have improved, she is still experiencing the symptoms and asks if there is any other treatment to get rid of these symptoms that are really bothering her. So, for non-response to treatment, which is usually described as a symptoms that is persisting after 12 weeks or longer, which is suggesting of chronic rhinosinusitis. According to the European position paper on rhinosinusitis, one may consider referring the patient to specialists or consider a referral for allergen immunotherapy. And we also need to review for red flags whenever the patient comes back for follow-up for persistent unilateral nasal obstruction, blood-stained discharge, malodorous nasal discharge, or severe persistent nasal congestion and anosmia. In summary, allergic rhinitis is common, and the symptoms are triggered by an immune-mediated response following exposure to allergens. And the diagnosis can often be made clinically, supported by a positive response to treatment with a non-sedating H1 antihistamine and/or a nasal glucocorticosteroid. And allergen confirmation with either serum testing for allergen-specific immunoglobulin E or allergy skin prick testing can be performed when there is diagnostic uncertainty or non-response to treatment, or if allergen immunotherapy is considered. So again, this is the desktop helper, and this is a QR code. Please look it up and read further on the practical guide to improve rhinitis diagnosis in primary care. Thank you very much.